Hey guys, good afternoon, everyone. Happy New Year. And I hope that 2024 is going to be good to everybody with a lot of prosperity and success and long-term relationship with us as well. Um, so everybody, you guys hear me well, right? Okay.
Yes,
So we have some questions. The topics. If you guys feel that any topic we need to discuss more, please feel free to let me know. But we have a few questions about certain aspects of cardiology that we encounter these issues on daily basis. I have a question about diuretics, what kind of diuretics we use. Um, Diuretics management, especially in the setting of hypertension and congestive heart failure, is really uh, the kind of uh, great example of the art of medicine, right? So almost all diuretics work at certain capacity, but patients' response to diuretics, uh, can be or can differ from one patient to another. You have to understand that certain diuretics can be a little bit stronger than others. Um, but when you practice cardiology, at certain degree, you're gonna feel that I'm gonna go with this diuretic, and then I'm gonna progress to another diuretic to achieve my goals. Um, and again, management with these kind of medications uh, uh, tends to be dependent upon your comfort and your patient response. And exactly, this is what I say always. This is probably the perfect example of the art of medicine. So we have different kinds of diuretics. We have the thiazide diuretics. We have the hydrochlorothiazide, chlorthalidone, and the metolazone. The chlorthalidone was the medication used on the OLHAT trial. The NIH funded the trial that found that patients with hypertension treated with this kind of diuretic, they will have better control of blood pressure and less progression to congestive heart failure compared to other hypertensive medications. And this is why, if you look at the guidelines, hypertension management should rely on some kind of diuretic to manage the sodium in your patients. And you cannot really reach a diagnosis of resistant hypertension unless you are on a good dose of diuretic. And I keep telling my patients, whoever works with me in the clinic, I tell them that the sodium molecule is very heavy, is very difficult to manage, and it has a lot of work. It requires a lot of work between the heart and the kidneys to get rid of. And the American diet is really full of sodium and salt. So diuretics are really required to hypertension management, and you have to use them always when you can. I tend to use either hydrochlorothiazide 25 milligrams or chlorthalidone 25 or 50 milligrams. Uh, when I was actually in training, if your creatinine above 1.5, 1.6, you can't use thiazide diuretics, especially hydrochlorothiazide and chlorthalidone. But there's actually new data. Even if you have a stage 3 to 4 kidney failure, you still can use these medications. So these medications, they are proximal tubule diuretics, and these medications make you lose salt and potassium as well as magnesium. This medication can increase actually the triglycerides level as well, but they are very effective and they are long term. Usually, you cannot rely on them in the settings of acute heart failure exacerbation. You have to use loop diuretics, which are much stronger than these medications. And I tend to like metolazone a lot. I tend to like metolazone a lot. Metolazone works in any kind of kidney failure as long as you can make urine. And metolazone is very powerful. It works at different location than loop diuretics, and sometimes combining this medication with loop diuretics works very well. And always when you do metolazone, do it like once a week, once a day for a week, and then every other day after that. And even sometimes if you want to use it once a week for your patients, you can do that. And I would encourage any one of you, even Nick and Dee and all these who works with me in the clinic or has some experience with me in the clinic, they know that patients sometimes can be stayed or can be left on this medication, and that will prevent a lot of hospitalization for congestive heart failure. So I like this medication a lot. This is thiazide diuretics. Any question on those medications? All right, so the next ones are loop diuretics. We have the Lasix furosemide, we have the torsemide, and we have the bumetanide or Bumix. These medications are strong, powerful. They have IV, IV form to give your patients. And nowadays, actually, we have sub-Q Lasix. It's kind of expensive nowadays. But it's been FDA approved, and actually that can be very, very helpful for some of our patients. Lasix or furosemide is absorbed by kind of 50%. So the 20 milligram of IV Lasix equals 40 milligram of PO Lasix. Remember that if your patient has significant edema, the gut is going to have edema as well, and the absorption is going to be affected. So keep that in your mind. There are differences in responding to Lasix compared to other loop diuretics. So the Lasix tend to be not very predictable, but it's a great medication. You can go from 20 milligram to 120, 180 milligrams. At higher doses, it can affect the inner ears, as you know, and can cause tinnitus. But short of that, they are kind of safe medications to a certain degree. And you have to be careful about calcium. Usually you lose calcium and you lose potassium in the urine, and you have to replace always these kind of especially potassium in the setting of higher doses of Lasix in your patients. You can always increase the dose in the case of Lasix, and if you want to do it 3 times a day, you can do that, or even 4 times a day, or Lasix drip in the setting of ICU management. So you can do a lot of stuff with the furosemide or Lasix. And remember that in patients with hypokalemia and you're starting Lasix, you have to check their potassium. And in general, if you have somebody in the facility with some signs of congestive heart failure exacerbation, you're gonna start this kind of medications. Make sure to get some blood work within a week to check your potassium level and magnesium level. So you can start with the Lasix. It comes 20, 40, or 80 milligram, or even 60 milligrams. And if you feel your patient is not responding to Lasix, you can change to either torsemide or Bumix. Torsemide is 2 to 4 times stronger than Lasix. So the 20 milligram of torsemide equals between 40 to 80 of Lasix, and the Bumix is actually 4 to 8 times stronger than Lasix. So if you think that your patient is not responding to Lasix or furosemide, feel free to change to torsemide or Bumix. And torsemide and Bumix, they seem to have better bioavailability when it comes to gut absorption and response, even when you give it IV compared to Lasix. So Lasix, some people, they don't really respond to Lasix very well. Keep that in your mind. If your patient is not really responding, feel free to change to different diuretic. And this is really mainly the core of this lecture, is to let you know that some patients do not really respond to Lasix very well. In that case, changing torsemide or Bumix is not a bad idea. And sometimes you have to combine you have to work on different diuretics, combining like the loop diuretics with the thiazide diuretics for patients to work. So you can do some Bumix or torsemide or Lasix and add some metolazone to your patients. check blood work in the next 3 to 5 days, and then readjust based on your patient response and your blood work response as well. Uh, any questions about the loop diuretics? Okay, so the other diuretics that we use are the distal tubules, which are the aldosterone inhibitors, the spironolactone, aldactone, or eplerenone. The spironolactone is perfect medication. I love this medication. I mean, patients, people who work with me in the clinic, they know that usually I tend to go to this medication almost second line in terms of hypertension management. Keep in your mind that you can use these medications as chronic kidney disease, but across the board, any kind of kidney function, if you're going to start these medications, the eplerenone or spironolactone, you have to check blood work, check kidney function and potassium level within 1 to 2 weeks after starting these medications. These are standards of care. So if you fail to do that and your patient has hyperkalemia down the road and something happened, you're going to be liable. So be careful about that. If you're going to use spironolactone, aldactone, or eplerenone, you have to check blood work in the next 1 to 2 weeks. These medications tend to work very well on lower extremity edema as adjunct to other medications such as metolazone or furosemide or loop diuretics. Wonderful for managing hypertension. About 10 to 15% of resistant hypertension patients, they tend to have hyperaldosteronemia, so these medications will help. And this is actually the Abbott guy, I think, one of them. So these medications tend to work well. If your patient is having gynecomastia because of spironolactone, eplerenone should not affect that and should not affect the genitalia of your patients either. So in women, usually start spironolactone. In men at younger age, you may need to start eplerenone, and the same dose, 25 to 50 milligrams in both of these two medications. Higher doses can be used, but they tend to lose their antihypertensive effect if you use them above 50 milligram PO daily. So we tend not to use them. Dermatologists like to use higher doses of spironolactone to prevent acne and PCOS and stuff like that. Again, you have to check potassium level, kidney function. I've had 2 patients throughout my career. They had actually potassium above 6.5 from using these medications with no previous history of significant kidney failure. So be careful about that. You don't want to miss anything like that. Hyperkalemia in patients can be lethal. So, combination of multiple loop diuretic or thiazide diuretic and the aldosterone inhibitors can be MRAs can be very helpful. And the MRAs or aldactone or eplerenone are very effective medications in HEF, PEF, and HFrEF heart failure with reduced and preserved ejection fraction. So always try to use these medications as much as you can, if you can, and if your patient can handle them in terms of blood pressure. The other diuretics, actually, the SGLT2 inhibitors, the Farxiga or Jardiance, these medications, they did a trial not long time ago, and they found if you put your patient on loop diuretic and SGLT2 inhibitor versus loop diuretic without SGLT2 inhibitor in the setting of congestive heart failure exacerbation, there's about 1 to 2 liters difference in diuresis in 48 hours. So these medications can cause significant diuresis because they make you lose the salt and glucose and the sodium in the urine. And that's actually very helpful in congestive heart failure management. So always remember that if you have patients with congestive heart failure, especially HFrEF, and actually even HFpEF too, feel free to use these medications. They tend to be a little bit expensive. I'm not sure if you're going to have pushback from the facility, but they are wonderful medications and they can cause significant actually diuresis. You can feel it sometimes. So always remember that too. Any questions about diuretics?
Dr. Ibrahim, what is your recommendation to hold diuretics for hypotension?
I'm very aggressive. I'm very aggressive. When I was in training in Texas Heart Institute, we used to actually in the heart failure clinic, we never measured blood pressure. So you sometimes you may need to go with clinical. I'm not advocating for that, obviously, but diuresis should not really. If your patient is not hypovolemic, if you see your patient, let me give you example, half pref or half pef, edema lower extremities, little bit of ascites, and blood pressure of 85, I would continue Lasix. I would. Uh, some elderly lady, her tongue is, you can feel that there's hypovolemic, dehydrated, and hypotensive. I would be careful. But if you're, if you look at the Frank Starling law, if you're gonna increase the dimension, if you're gonna increase your ventricular dimension, right, your ejection fraction is gonna actually come down because the shear wall, the wall stress is gonna be increased. So what you have to do, you have to diurese your patient so your ejection fraction is gonna improve. So diuresis will help that and will help heart function. Hence, the blood pressure is gonna come up a little bit. So I'm not really worried about hypotension in the setting of edema and CHF exacerbation. That's a mistake. And although sometimes you have to have a fist fight with nephrologists about stuff like that, but you really do not understand. They do not understand the physiology of congestive heart failure and how you treat that. And they focus mainly on, really, unless you're very talented nephrologist, they focus mainly on BUN and creatinine.
Okay.
Granted, listen, if you look at the art of congestive heart failure measurement management, you can see that your patient is going into a little bit dehydration, hypovolemia if the BUN is really, really elevated. That's before the creatinine. So that can give you hints, but take it into take it in clinical context. In other words, your patient is getting dry, BUN is elevated, a little bit hypotensive, then you have to be careful. But your patient is full of edema, third spacing, and the BUN is elevated. In that case, if you're at acute care settings, you may need to treat with albumin, for instance, and keep diuresis on. But not every hypotension case you have to stop your diuresis. No.
Okay, thank you.
Any other questions,
Hey,
guys?
Dr. Ibrahim. Yes. Hey, it's Jackie. In the long-term care facilities, a lot of times these patients aren't seeing nephrology. Maybe once or twice a year, nephro's coming by to see them, and they're not really going out. What is your, I have a patient who's just newly started on dialysis, but she's also on Bumex 3 times a day. And I haven't really seen a lot of dialysis patients also on PO diuretics. What's your recommendations with that?
Yes. So actually, that's great. If you think that dialysis is going to be replacing the diuresis, you're mistaken. So nephrologists like when patients can make urine, and they will try to encourage that. So yes, we can do that. We can do PO diuresis, IV diuresis, sometimes in patients on with end-stage kidney disease. That's not going to be your primary way to get rid of the volume overload. But as long as they can make urine, yes. If they stop making urine, that's very advanced stage 5 or end-stage kidney failure. And in that case, it is what it is. You stop the medication. But if they can make urine, in other words, you have to differentiate between end-stage kidney disease, hemodialysis with making urine versus end-stage kidney disease, hemodialysis, they're not making urine. And if they are making urine, you can keep the urine flow and you can keep the diuresis.
Okay, thank you.
Any other questions, guys? All right, so fluid restrictions. I'm kind of liberal when it comes to fluids in even heart failure patients. We usually say 1.5 liters or so, but it's not really as much as fluids or as much as restrictions of fluids when you treat these patients. What you have to what you have to care about and be worried about is really the salt. The salt is toxic, and the sodium in these patients is the issue, not really as much as the fluids. So they can drink and they can have 1.5, 1.7, 1.75 liters of fluids a day. That should be okay. But we cannot encourage any form of salt intake. And this is how I have been practicing for the last 10 years, and sometimes people don't agree with that. But I am a strong believer that it's extremely stressful to prevent your patient from being able to drink. And if they're drinking and eating salt is dangerous. But if they're drinking only water and or non-salty fluids, they can do 1.5 liters easily. That should not be an issue, even for elderly, frail women. I'm okay with that. Now there are maybe exceptions where your sodium is low. Blood sodium is low. In that case, you have to restrict fluids, and that's going to be advanced heart failure. What is the number one indication for long-term survival in heart failure? Is hyponatremia. If your patients start having hyponatremia and heart failure, that's really advanced stage, and they usually don't do very well down the road. How about the short-term heart failure survival? Is kidney function. So kidney function short-term and long-term is hyponatremia. So when you reach the stage of hyponatremia, that's very advanced. In that case, you have to be careful about water intake. But short of that, I think you should be okay. Any questions about that? All right. I was asked about metoprolol. So remember that everything in medicine is class effect except beta blockers. When it comes to heart failure management, you have only 3 approved medications, which are metoprolol succinate or toprolixel, carvedilol, or bisoprolol. There's difference between metoprolol succinate and metoprolol tartrate. You can do metoprolol succinate twice a day if you want. In fact, when I was in training, we used to do it twice a day, but it's FDA approved to be once a day, so it is what it is. You can use it twice a day or once a day. Metoprolol tartrate is twice a day, and it can be used more than that, more frequently than that if you elect to do so. We used to do it every 6 hours in training. Metoprolol tartrate is not approved for heart failure. Metoprolol succinate is approved for heart failure with reduced ejection fraction, HFrEF. I'm talking about heart failure, HFrEF. The other medications, carvedilol, and I mean, it can tend to be the same, but remember that the metoprolol and bisoprolol are beta-1 selective. The carvedilol is non-selective beta blocker. So if you have patient with COPD and they're wheezing, for instance, then it's better for you to choose something like metoprolol or bisoprolol and not carvedilol or propranolol. Any question about that? Any concerns? Beta blockers. So SGL2 inhibitors, calcium channel blockers, the dihydropyridine, 9-dihydropyridine, they tend to have class effects. The ACE inhibitors, ARBs, but not the beta blockers when it comes to heart failure, guideline-directed medical therapy, and HFrEF management. So keep that in your mind. So if your ejection fraction 20% patients on metoprolol tartrate, you may need to switch it. Is that fair? So antiarrhythmic medications, we have the Vaughan classification of antiarrhythmics. So you have the class 1 sodium channel blockers, you have the class 2 beta blockers, you have the class 3 the potassium channel blockers, you have class 4 the calcium channel blockers. What I want you to remember from this is sodium channel blockers class 1C, like flecainide or propafenone, are contraindicated if your EF less than 50% or CAD. If your EF less than 50% or CAD, propafenone or flecainide are contraindicated. If your EF less than 50%, you should not use sotalol. I've used it myself for ventricular arrhythmias and atrial arrhythmias in the setting of AICD, so I can do that. You can't. It really in the guidelines says if your EF less than 50%, you should not use it. If you have history of CAD, do not use flecainide or propafenone. You can use Maltag, amiodarone, dofetilide, or sotalol, but you cannot use flecainide or propafenone based on the CAST trial 1991 from New England Journal of Medicine, where they found increased mortality. So be careful about that. Let me repeat that again. EF less than 50%, no flecainide or propafenone. Okay, CAD, history of MI, no propafenone or flecainide, even if your EF is normal. Okay, if your EF is low, no sotalol. Amiodarone, you can use it everywhere, anywhere, no big deal. Dofetilide, you can use it, right? But remember, dofetilide, you have to be in the hospital for 3 days. Sotalol, if your EF less than 50%, do not use it. If you have CAD disease, you can use sotalol, you can use amiodarone, you can use Maltag, you can use dofetilide, but you cannot use propafenone or flecainide. So keep that in your mind, guys, please. So we don't want to do mistakes like that. You know, EF 35% and your patient is on flecainide. That's a no-no. That's a mistake. So at some point, we probably need to do a lecture about antiarrhythmic medication. We've done it before, right, Nick? Yeah, we may need to refresh that just to remind everybody, because, you know, it's easy to forget stuff like that, but so important, so important. And that's a huge mistake that, you know, God forbid, if something happened, is not going to be forgiven. Any questions? All right. Okay, guys, that was a little bit longer than what we expected, but if you have any questions, please let Nick know, and we can just discuss it. Probably every once in a while, I'm gonna, you know, whenever I have a chance, I'll update you about what's going on in the field of cardiology. Stuff is really coming and advancing quite a bit. I didn't really have any idea about the chlorthalidone and hydrochlorothiazide that it can be used for patients with chronic kidney disease until really recently, because the data came in last month. So stuff is really moving in frequent basis. Like, for instance, nowadays, dual antiplatelet therapy after stenting, you can stop the aspirin after 1 month, keep the Plavix or Brilinta or Effient for 1 year, and then stop it after that. Just keep aspirin only. If you have triple therapy with anticoagulation and dual antiplatelet agent, you should not really send your patient home from the hospital on triple therapy anymore. You can't do that. You have to do anticoagulation, single antiplatelet agent. So stuff is changing quite a bit. So just keep that in your mind.
Dr. Ibrahim,
Yeah.
what about dual antiplatelet therapy and stroke? I'm seeing a lot of
Yes.
that come through.
Right. Yes. Actually, there's a little bit update in the European guidelines recently. It is reasonable to do it for a month, but not beyond that. So the bleeding, the bleeding risk outweighs the benefit beyond 1 month of dual antiplatelet therapy. It's really back and forth, but what's more important in ischemic stroke, I'm presuming vascular ischemic stroke, not, you know, cardioembolic, like AFib related, obviously. So you can do dual antiplatelet agent for a month. Then after that, you can continue with single antiplatelet agent. There's some old data. If you failed on aspirin and you have ischemic stroke on aspirin, then you can switch to Plavix only afterwards. There's some data about Brilinta. But when it comes to guidelines, you can combine dual antiplatelet agent for a month, and after that, single antiplatelet agent. And if you have received patient coming on single antiplatelet agent, there's no big deal. What's really more important in ischemic stroke patients, controlling hypertension and dyslipidemia, not really the antiplatelet agent as much.
Okay, thanks.
All right. All right, guys. We'll see you in a couple of weeks.